Well, now that the patient's progressing, the decision is what to do about it. So clearly something other than the lenalidomide and dexamethasone has to be done. So there's a lot of options now for multiple myeloma. So the treatments can be relatively simple, like adding something to the lenalidomide and dexamethasone, and choices for that would be the implicity, it's the elotuzumab. One could add daratumumab. One could add the bortezomib again, like she had before, and one could add ixazomib or carfilzomib. So there's clearly many choices to just add a third drug to the regimen she's already been taking. I think it's reasonable to add a drug to what she's taking because she's tolerated the treatment well, it's worked for quite some time, and knowing that one could kind of get rid of the lenalidomide at some future, third or fourth line regimen. When patients relapse, often the tradition is to do a bone marrow aspirate and biopsy to confirm the disease status and potentially to look at further cytogenetic abnormalities within the malignant cells. Often what mistakes genetically in the cancer cells that were present at the beginning differ. Things get added on as the cells continue to multiply. In this particular woman, I don't feel it's so necessary myself to do the bone marrow biopsy and genetic testing because at this particular time, I'm not sure it's going to change what I'm going to do. I already know she has high-risk disease. So if it shows high-risk disease plus another mistake, she still has high-risk disease. So I don't feel strongly that she needs a bone marrow aspirate biopsy. I know traditionally, though, it's done at many centers, and that's certainly fine as well.